Hello, everyone, and welcome to Equipo's new podcast series, Care Conversations, where we are going to be demystifying different theories that we have heard about healthcare. We are also going to talk about how technology is going to shape the future of healthcare. We are going to bring you eminent voices, people who have been pathfinders in different respective fields of their respective fields in healthcare. So today, I'm joined by Romanus Joseph and Rafael Alvarez. Hi, guys. I'm
Hello.
just going to give a quick introduction about them so that you guys understand who we are bringing to you. Roman is here. He's been a registered nurse. He's been a healthcare executive. He's had 20 years of experience in healthcare. He has varied experience around care management, population health, value based care. He has led and scaled RPM, chronic care management, transition of care programs across ACOs, IPAs, and digital health companies. His work sits at the intersection of clinical reality. He works around patient engagement, not just what looks good on paper. He has a reputation of being honest. I hope you're going to be really honest with us today because we are going to have a very tough conversation. So, welcome to our podcast series, Romanus.
Thank you, Fincy. Great
Uh,
introduction.
I hope I have done justice to you, and I'm going to move to Rafael now. Rafael here, he has around 15 years of experience spanning from home health, primary care, and value based care organizations, which includes ACOs, IPAs, and MSOs. His work focuses on connecting technology, operations, and clinical programs to improve quality, reduce total cost of care, and grow provider network. He has deep knowledge and experience on designing and executing value based contracting strategies, and he performs infrastructure and care modeling implementation. He has strong M&A capabilities, and we look forward to hearing a lot around money because that's what is the driving force in healthcare now. So, okay, welcome to our podcast series, Rafael.
Thank you, Fincy.
Awesome. So, those of you who do not know me, my name is Fincy Yusuf. I am the Vice President for Growth at Equipo Health. Today, we are going to bring you a topic that's very close to our hearts, close to all of our hearts. It's remote patient monitoring. So, off late, we've been hearing a lot about remote patient monitoring and the reimbursements that come along with it. Today, whenever we hear about other people speaking about RPM, everything is around KPIs, matrices, cost structures, but I think it's important that we go to the basics of RPM, why all of this came into being, and then we'll speak about the future of RPM. So just for our audience to understand, this is going to be a series of podcasts. We're going to be doing RPM multiple times. This is the first series, and we're going to be speaking about strategy this time. We are going to go into clinical outcomes and matrices later on in one of our following episodes. And Romanus and Rafael is going to be joined by our CEO Parijat as well. Today, let's speak about the basics. Let's start with what led to RPM, right? Let's speak about why RPM was initially spoken about the best way to catch issues earlier, especially in chronic cares, chronic issues or chronic ailments, right? Everybody used to say that let's push people to do RPM programs so that we can see or monitor them between visits, and obviously towards reducing hospital visits is the ultimate intention. Um, but during the course of technology growing, do you guys think, I mean, I'm just thinking out loud, do you think, um, where is RPM moving? Should it needle most towards chronic care, or should it move towards post-acute care or preventive care? What do you think? Where do you think it is going? Rafael, if you would like to start.
Yeah, absolutely. RPM can be used in several capacities. I've
Hmm.
always used it as a preventative care tool, basically monitoring high risk patients while they're outside of the doctor's office, collecting data, and then providing that data to clinicians to make the best preventative decisions. That's how I primarily used RPM, but it has evolved over time with chronic and post acute care. I think there's a place for RPM in every facet of
Hmm.
value-based care.
Yeah, I completely agree. What about you, Romanus? What do you think?
Yeah.
You've had a
So
lot of experience, yeah, in
yeah.
RPM. I mean, I know you told me stories about when you started and how things were. What's been your history and
Uh,
what's your take?
Absolutely. And this is where this podcast is going to be really, really great, having Rafael on the call and his background as well as mine. So Rafael said preventative care. Although I do not disagree based on my experience. RPM moves the needle most in chronic care and post-acute transitions. Um,
Mm,
and not so much in prevention. And I'll kind of explain why. Again, based on my experience, chronic conditions like heart failure, COPD, and diabetes benefits because RPM creates, that longitudinal signal, the historical capture of information while the patient's at home, not
mm,
some one-off data points. And post-acute care ultimately in RPM prevents those rebound events that you talked about earlier, Vinci, in terms of readmissions or unnecessary ED visits by catching that deterioration, that signal early after discharge. And preventative care is very, very promising, but it has, and Rafael, I think will agree with me, is that it has a ton of behavior change without the clinical why now. Meaning that if that patient's been sitting at home watching Netflix for 6 months, and now you introduce a device, that why is not there. It when
Yeah,
I, and what I'm trying to say is RPM works best when there's some sort of baseline risk, a trigger, like recently discharged from the hospital, recently discharged from a skilled nursing facility, where yes, they're stable for home, but we still need that bridge to kind of connect that patient with a clinician. Just just sort of like a hospital at home program, but not as acute, if that makes sense.
may I
but
pivot?
yeah, go ahead, go ahead.
So I don't want to make it seem like I'm about money and code and data points. The reality is, RPM provides an avenue to create meaningful relationships with patients. I think having those meaningful relationships with patients when they're outside of the home, coupled with the data, is how you manage a chronically ill patient.
Well, I mean, you need patients' active engagement. This is, I mean, in any other
Yes,
sense, this is one program, or RPM is is a segment of healthcare where you actually need patients to contribute as much as the care providers, right? So in that context, I mean, I'm just thinking out loud while you guys are, speaking. There, he spoke about post acute care, and I'm thinking, unless something happens, people do not understand the importance of what is happening in their body or with their health. So I don't know how much of preventive care is possible, but obviously that's the way people have to shift their mindset too. So
I
how
love
would
it.
you shift that mindset? How okay you I've heard stories of you having gone to help people set up devices, right? I mean, you've spoken about that.
Absolutely.
So are you
Absolutely.
seeing a difference in the shift in mindset?
I'm just right. I've been involved in RPM since 2013 in the state of Texas, where Texas Medicaid actually reimbursed the service before CMS identified the service as an actual reimbursable um, service. But simply stated, what we realized was there is too much time in between when a patient visits a clinician, and a lot of times chronic conditions can almost be quiet and can be causing destruction in a patient's body. And I apologize, I'm not a clinician, so I'm going to sound, I might not use the right verbiage, but a lot of times chronic conditions, diabetes, hypertension, these are silent killers. You don't know until a catastrophic event happens that you are or are not managing your condition properly. A lot of times, and we know this, patients aren't taking their medication properly. So we know that as adverse events can happen at any time. I look at it as this, right? My mother was a diabetic patient who had multiple strokes that went undiagnosed. If RPM had been in her life at that moment, I think we would have been able to see the actual changes in her and fluctuations in her condition. And I think a physician or clinician would have been able to diagnose this in a more timely manner.
Agreed. And just Romanus, from your perspective, like he's got a real life incident probably which made it really personal for him to speak about that particular segment. What when we said preventive or post, but even if it's post-acute care, Romanus, have you seen situations where, let's say, you expect the patient to take things seriously. You being a clinician, you being a you registered nurse, clinical nurse, you know the importance of them having to look at post-acute care as importantly as while they were hospitalized, during their hospitalization, etc. Right? So, do you see the I don't know if it's the right word to use, but the lack of the better word, the excitement of having a new gadget, right? Generally, people look at it as the excitement of using something new. Does that wear off? And do people just move out of RPM or stop engaging that
Yeah.
way? Have you seen?
So I'll use my transitions care example, and I use it in two ways. One, where if they're a patient being discharged from the hospital, that excitement is there, but it does wear off once they get home. I've seen it. We try to get them to last up 30 days of engagement, assuming it doesn't take a whole week to kind of set up these devices, right? There's a technology piece. There is a learning curve, but it has
Mm,
gotten much, much better. Now, take the example of someone who wasn't discharged home directly from the hospital and goes to a skilled nursing facility. Now, just take this example: stayed at the hospital for 7 days and go to a sniff for 20 days, sometimes even longer. That patient is drained. That patient's family support system is drained. By the time they get home, there is some excitement, and through motivational interviewing, encouragement over the phone, there's only so much you can do. And sometimes what I found out was the most important thing, sometimes for those especially that live alone, is that there's a hierarchical need, and you can use Maslow's hierarchy of need to determine what's going to fit. Where does RPM fall in that bucket? And
Exactly.
oftentimes it's get me to a doctor soon,
right.
because I've gone from the home, hospital, sniff. Now I'm home. RPM is not on that hierarchy of like, get me set up soon. And this is just coming from literally from, this
Yes.
firsthand experience. But it's oftentimes Meals on Wheels, or can you talk to my daughter to help set this up, or my son?
Yeah.
Assuming that relationship is good, because if it's not, then it's the neighbor. I've gone as far as the neighbor down the street to help set up the machine. So
Yep.
that excitement's there. It's just it fizzles out quickly, depending on
Yeah.
which discharge disposition the patient goes through.
May I jump in, Fincy? I agree 100%. Active participation requires you to want to participate.
Yeah.
And patients, a lot of times, they find this equipment to be a burden. And this is going to sound crazy, but a lot of times they don't want to see a negative reading, a high blood pressure, an A1C that's out of control. So they avoid it,
Yeah.
right?
Yeah.
We tend to do that as human beings, right? And what we have to realize is we're trying to change the way they think and also their habits. And we have to
Mm,
be very mindful of the way they think and what drives them. Is it your grandchildren? Do you want to stay alive another 10 years to be able to hold your grandchildren? Do you want to
definitely.
have your appendages, from diabetes, not have a leg or a foot cut off so that you can actually walk and engage and go to events? So I think it's finding what drives a patient, what really
Mm.
touches their heart, and use that as an avenue to introduce the technology and kind of make it more of a day-to-day routine and not something that's a burden.
You've come to the right point, because that's what I wanted to ask. RPM and technology. We have medical devices and we have technology, and we are trying to merge the two and bring technology amidst all of this. When life gets busy and people are moving towards their busier life, they get back into action. I don't know how much people remember to do these things, right? So, what's the importance of technology in keeping them engaged, patient engagement? You are speaking about personal, personal things that people should remember. How long do you want to live and all of that. But how do we induce all of this as a factor in technology so that technologists can remember this while they devise a solution? Now everybody says it has to go hand in hand, but in a way, we actually should start thinking about who should be positioned to lead RPM long term, right? Should it be payers? Should it be tech companies? How do we position it so that we can help patients? That's the need. Take it. Whoever wants to take it. Rafael, Romanus, take it.
So sorry,
You're
the question, can you just, the question
Yes, I
again?
just
Yeah.
want to. So I wanted to understand, who you feel
Mm.
is best positioned to handle um, RPM long term. Who should it be? Should it be health systems? Should it be payers?
Oh,
Should it be
okay.
technology? Right? I mean,
Yeah.
you need patients in the middle of all of this. You
Yeah.
need devices, technology, patient to work in tandem. So
Yes.
who should be leading
I
from
can,
the forefront?
want me to take it
Go
Let
ahead.
first?
me start real fast.
Okay, okay, you
Well,
got it. Yeah.
I've seen everybody try and fail. I'm just gonna say
More.
that right now.
Yeah.
Yeah.
Multiple technology, software companies. I've seen health systems. I've seen small home health agencies, independent PCP practices try to
Mm.
initiate and fail. And there's several bottlenecks for different organizations. But ultimately, who is best to break through? I think you need a little bit of everybody. You need the technologist to create the actual hardware and the software.
Mm.
The health system is the one actually engaging with the patients, executing services. And then, managed care, they're the payer. So they're going to decide whether the service is reimbursed at what rate or not, and whether it's equitable to the provider. So I think you need every piece for it to be a successful program. And who's going to lead the charge? I don't know why I'm leaning more towards technology. Apple, you've got the Apple Watch. Look at how many people have Apple Watches now, and they're
Mm.
just pulling data on people. What needs to occur is these data points need to be taken seamlessly and not necessarily affect the patient's day-to-day life, such as the Apple Watch. So everything just flows. And I think that's when you get better engagement and ultimately success in the program.
Okay. It's your
Yeah,
take.
yeah, I actually like what Rafael said in terms of the technology piece. Again, assuming we're not talking to folks age groups like myself, I'm 42. And like, to Raphael's point, I think everybody's going to lead on their own separately. But I'm just going to use the technology piece. If Apple and other companies like that are able to kind of break that barrier of onboarding or that initiation of like, this will not take me 5 PDFs to understand what I'm doing with this watch, that is
Yes.
helpful. That is a role they must play. I wouldn't expect the tech company, let alone the payers, to build clinical trust with the patient, because at the end of the day, that's going to come from what was the other the health system, the provider, and you may want to call it that, right? So that's clinical trust. And then to Raphael's point, the payers control the incentives because it's the hospitals they paying the patients, and the tech companies build the cool tools. And if they could limit the barrier of onboarding, I think that's gonna really, really help. But ultimately, in a perfect world, I'll be honest with you, hopefully in a not too far distant future, the winners will be ecosystems, and it could be a state, it could be a county. I don't know what it looks like, or it's a health system with a big enough payer source and technology partnerships. We'll build some sort of ecosystem where reimbursement, workflow, technology reinforce each other instead of fighting each other. And again, I know it's 2026, February 6th. Hopefully this is not, like 10 years from now, because at the end of the day, RPM fails in silos and succeeds in these coalitions of these three big parts, in my opinion.
I know you called out Apple, Rafael. I'm a technologist at heart, so somewhere I feel for technology, but at the same time, we need the backing from health system. We need backing from providers. We need the clinical, yes from them, because at the end of the day, we need to know what we are building is right or not, correct? And but I somewhere I still feel you guys are speaking about having an ecosystem, right? And being in the middle of an
Yes.
ecosystem, the patient being at the center, and everything revolving around the patient. But I don't know. I don't know if we are, again. You said 2026, and we are speaking in 2026, and we shouldn't be too far when this should happen. But the cost of building technology, the cost of building these devices are also there in and I'm sure all the med tech and health tech people are going to agree with me when they hear this, because the cost of building the devices, the sensors that give you the most appropriate and making it really seamless, like you meant the CGMs, which you just punch onto your skin and that
Mhm.
is reading automatically, or you tap and get the reading out. There is a cost structure to that. Should we speak about the financial, is RPM now slowly I don't know, I mean, should we be speaking about it or no, or not today in our series, but I think we have to touch base now that we've come to this part. I wanted to understand, is it today more of a clinical transformation, or is it a financial survival strategy? I don't know where you guys are going to wave towards, but I would love to hear what you guys think. Please keep in mind that medtech devices or health tech technologists need the money to build the technology
Yep.
and the innovation that you guys see. But yes, please.
I'll jump in. When I first started in the RPM world, a little bit over 10 years ago, equipment was roughly $2,500. And the funny thing is, right, this equipment actually plugged into the walls like it was landline. That is how the communication took place. There was no SIM cards, there was no technology. I'm sure they could have done some little mini satellite, but that would have been astronomical. So the actual equipment, and it had everything. It had an O2 sensor, blood pressure cuff. It had multiple functions within one contained unit. That unit was $2,500. And we used it on the home health side as preventative care for our very high risk patients. We would equip them with a monitor while our nurses were away. We did that over 10 years ago, right? Now you can get equipment for literally $50. You can go to your Best Buy, your local supermarket, buy a blood pressure cuff that syncs with your phone. Now connectivity is through your phone, so it literally has a zero cost for the provider, right? Because ultimately the provider is absorbing those costs. And like you mentioned, return on investment. When does it make sense for me to make this investment on a patient for value-based returns at the end of the year or whatever, right? We'll just say. So with that all in mind, equipment now is just so affordable for people and so seamless. That barrier to entry, the monetary cost, I'm telling you, it was a severe limitation in the past. Now I feel like almost anybody can participate with very little investment. And now providers,
Yep.
they may not even provide the equipment to the patient. The patient may actually purchase the equipment on their own and just provide the data points or
Mm.
the connectivity integration for those data points to be sent, cellularly. So the idea is, this whole barrier of cost has greatly been reduced. Now, don't
Yes.
get me wrong, there is some new technology that costs thousands of dollars for very specific chronic conditions.
Yes.
I'm not talking about that right now. I'm talking more about a more simplistic RPM, managing hypertension, managing diabetes, more on a larger cohort.
Okay. Okay. What about you, Romanus? What do you feel?
Yeah, so I'll lay on the clinical side. God, I'm shocked of how much that stuff costs. That's, yeah, that's a lot of money. So I guess what I would have to say is that RPM right now is often sold as a financial survival, but in my opinion, it only sustains if it turns into some sort of clinical transformation. Um,
Yes. Yes.
like programs purely launched from reimbursement, and I've been there,
Yes,
tend to
they
collapse
exist.
under the workflow burden that the clinicians actually using it have to deal with on a day-to-day basis. So what I'm trying to say is, now this is my process improvement background speaking, is that unless the clinical team, whatever you want to call that team, like redesigns their care models first to accommodate for this tech, um, I am certain it will lead to better outcomes, especially with what, my God, the capabilities of some RPM devices that
Mm.
naturally, and without a ton of Hail Mary prayers, that the economics will follow. And so what I'm trying to just close out saying is that RPM programs start with revenue, absolutely, without a doubt, just like anything, to be honest. But outcomes are, in my opinion, is what keeps it alive. Outcomes is an ED reduction in ED visits, reduction in adverse events that Rafael brought up earlier, and admissions, and all things that keep them away from the hospital and at home watching Netflix. I'm sorry, I keep saying Netflix like I'm sponsored by them,
Uh,
but anyway,
Get
I want to.
it's true.
them the sponsor. You said Netflix twice,
Right.
and you said Apple sponsor as well.
Yes. Anyway, that's just my take on it.
I want to just jump in.
Yes,
I
please.
am not an advocate of getting your whole panel on RPM. I really like stratifying high risk patients that can really utilize the equipment. So, does it drive revenue? Absolutely. And do some organizations, PCPs, feel like the larger the panel, the better because it's very predictable income? Great. I pivot and I really agree with Romanus. It's all about outcomes. We're in value-based contracts right now. We're trying to close quality measures. We're trying to get incentive bonuses at the end of specific periods for reducing unnecessary utilization. So using RPM as a very strategic tool for very specific high-risk cohorts is more of what I believe is the best use of RPM.
Fantastic. I mean, I I don't know. So when we were devising the RPM solution at Equipo, we needed to speak to people and understand what's happening and what is the problem that we need to solve. So I remember having a conversation with one of our current clients. They are our current clients now, but when we had the conversation, they were speaking around RPM and how the readings come, and when they go into the devices platform and see the reading, and they the time that they spend, etc., etc. And it was so clear to us how much of operational burden they have, the operational burden they have to go through just to make sure that they can see the outcomes and take decisions, right? I mean, the time it takes for them to see the actual patient. So when we were deciding, this is when I really wish Parijat was part of the panel, but I'm sure he's going to join us next time. But Parijat would have been able to speak about this probably much more than I could, but I hope I do justice. But when we were building a Keepos RPM solution, we it was so clear to us, and then we had to go back and ask them, tell us about your day. What does your day look like? What happens in the morning? What do you do next? What do you do next? We're talking about people who should be looking after patients, and they are having to spend time on operational efficiency or burdens that they are having to face because they adopted technology. Now, people like us who are building technology, I mean, I felt sorry for them that we there wasn't technology at that point to help them get out of the burden. But anyways, long story short, when we build the solution, we had to keep in mind that you stratify your patients so that they just look at the ones that they immediately have to look at. The ones that probably hasn't taken a reading for 5 days, or um, chronic patients with other chronic conditions, comorbidities. But yeah, I mean, we are there. Technology is there. But since we are speaking about operational burdens, what do you think is one of the most um, out there operational mistakes that organizations make when they are trying to adopt RPM? Let's say that there's a provider group who wants to like start doing a RPM, and they're just getting to know things. In your experience, what is the one operational mistake that they've made, and what would be your advice to them when if they want to get into RPM and they are at this point probably they're a little tensed about adopting technology, whether it would be a burden for them? uh, Guys, any of you, I mean, who wants to take it?
Yeah.
I think ultimately it's communication, right? If people within the organization do not understand what they're doing and why they're doing it, and why they're adopting a new layer of work on top of their 50 layers that already exist, they tend to not do it. So
Yeah,
to me,
yeah.
right, all stakeholders need to be involved, as well as a champion. There needs to be somebody who advocates, loves, and really pushes the program forward. But when the program is siloed within a system, it could even be as small as a PCP office. When the front desk doesn't know that there's an RPM program and why it's going on, and a patient
Mm.
calls,
Yeah.
it's up in
I
the air.
agree. Yeah, I agree.
So everybody within, whether it's a practice, whether it's an organization, they need to understand, why are we doing this? What are we trying to achieve? And ultimately, what does success look like? But when you don't communicate that to every stakeholder, and since everybody in some way touches the patient, even if you're in medical records, you're still touching the patient's information. I feel that communication needs to be clear in the organization for success.
Spot on. I completely agree.
Yeah.
Romanus, you have something to add? Is
Yeah.
there something else you were thinking?
No, it's very much. I'll just actually use communication as an example. Now, having worked at a health system using RPM, being involved in transition care, chronic care management, we tried to operate it with an ecosystem that was that it involved communication from the inpatient team, the transitioning team, and then the physicians that we were following up with and conducting that appointment, and so on and so forth. Now, that took a lot of work. Then I've also been on the opposite side where we were just doing RPM. No relationship with the care management team in the hospital. Man, that one's rough. That one is really rough because you got to call the hospital to find out. Say you get an HIE ping, that patient's at this hospital. You got to call that care manager, understand, hopefully, are they getting closer towards discharge? And first of all, you also got to get through the privacy and HIPAA laws, right? Like, a nurse isn't going to just give you a verbal report over the phone, despite introducing myself as director of nursing for the RPM company. I can get by with it, but some others will have a challenge. They really will. And so that's one communication breakdown from the hospital to being discharged. And even tried that approach with post-acute facilities where there was an established relationship. That helped, but there was also communication breakdown. For example, they were ordering DME devices, then we would also help them order DME devices once they were discharged on top of that RPM devices. So communication, to Rafael's point, woof, that is absolutely key. But a second close one would be just knowing your current processing, your workflows. Like, are you communicating already? Because you can't rely on the technology to help communicate for you. It'll communicate the signals, sure, but what do you do with it?
Yeah.
Are you copying and pasting it and emailing it to the doctor? Are you making decisions? Yes, the answer is yes. But there's a lot of orchestrating things, and
Yeah, I mean,
do that
orchestrating,
first.
that's
Yeah,
probably.
yeah.
Yeah,
Do that
exactly. I
first.
mean, two parts, right? I mean, one part is when you adopt the technology, whether the technology is doing its job of doing the communications that it's
Yeah,
supposed to do. What's the technology supposed to do?
yeah,
It's supposed to bring you the right information. The
yeah.
technology is supposed to bring you actionable insights,
Right.
outcomes, measurable outcomes, etc. But that's it.
Yeah,
The other side is the human interaction,
yeah,
and both of that orchestration. I completely
yeah.
agree. I mean, no
Because
technology can
yeah,
without
because
human.
Rafael talk about outcomes too. If you don't have your processes tightly woven, you'd be looking for those outcomes all year long, into the next quarter, into the next, scratching your head. Why? Well,
Yeah.
it's obvious, isn't
Well,
it?
I've seen lot of providers, and no offense, because they do have a lot of burden as it is with the current cost structure to maintain business, keep the shop open. But along with that, if a program becomes a barrier, it's about choosing what's priority, right? If your patients are visiting you and you're able to manage it outside of the device, probably you will try to do that, while they know that the better way probably is using a program that would help them orchestrate things better. But yeah. Okay, so since we spoke about operational cost, operational structure, orchestration, etc., where do you see RPM having the biggest system level impact? Is it going to be outcome or cost? We spoke, I think we touched base a lot around that, but where's the system going to fail?
Where it's going to fail or succeed?
Both. Let's talk about success and failure. Where do you think what do you think
Look, I still am on the preventative and outcomes bandwagon, and I know Romanus is going to disagree. But right, I'm looking at younger cohorts. Look at us, right? We have grown up with the Apple Watch. We know no different. I've got multiple models, right? It's already gathering data on me. I use a heart rate monitor to get my HRV and other stats. And I myself, as a younger demographic, am creating a portfolio of my own health data. I believe in the near future, technology will not only be seamless and available monetary wise, but everybody's going to have a wearable device that's going to be taking information, that's going to be consuming information all day long. And I think we're going to use that information to negotiate insurance rates and do a plethora of other things. So I really do believe in the near future, even myself, like, why am I taking all these data points on myself? I mentioned earlier, my mother had strokes, hypertension, diabetes runs in my family. I myself am implementing a preventative routine in my life so that I can live longer for my children and my grandchildren. So I believe, unfortunately, there are older demographics of patients that we cannot change. We can only manage. But there are younger populations that are growing into the Medicare population and will grow into the Medicare population that are initiated, that understand technology, and that will be ready for this. So I believe in the near future, it's going to be more of a preventative landscape where we're just collecting data seamlessly on all age ranges, from literally born to death. We're going to be consuming data.
Okay.
Yeah.
Okay.
I
What about you?
actually won't disagree with Rafael, and I think the biggest
I'm not
impact
surprised.
was it.
I'm not surprised.
Yeah,
I kind of knew you were going to
that's
agree
right.
to that.
Yes, because we're R&R. I'm kidding. Anyways, that's a soundbite. Okay, so I think the biggest impact is covering all ranges now. It is access, and let's be honest, Chat GPT Health, and I think even what do you call that? Claude Health has impacted the
Broadband?
scene.
Broadband.
Right? Is it something like that? I forgot their actual names. I think
Yeah.
the biggest impact is access, right? That I think is being fixed literally in the last, in the last 6 months, even sooner than that. But then what happens next is with outcomes following and then costs lagging. To Raphael's point, RPM does extend the care beyond the four walls of the hospital or of the clinic, wherever the patient is being discharged from, into their daily lives. But I think, again, better access enables better or earlier intervention, which then leads to cost reduction. And then the downstream effect will be the cost ultimately, but not the primary lever. It's just RPM really expands the front door of care, in my opinion. And it's not uncommon. I've done this myself, where I've uploaded my health information into ChatGPT. I'm not using any RPM device, but maybe I'll use my step counter just to run an analysis on what that looks like. And it's not bad. It's actually pretty good. I mean, it reminds me
Yeah.
how unhealthy I am and overweight I am, but the analysis is not bad.
Yeah.
We haven't spoken, and I think I'm going to keep one episode specifically to speak about technology and
Yeah.
about clinical validation and how much physicians or providers are going to accept the data that you guys have just spoken about. You spoke about your step counter, and Rafael, you said you already use an RPM device because you are into preventive care, right? We will talk about that in detail, but obviously, being a technologist, um, there's pros and cons to using technology. So I don't know when the providers will get to a point where they would say that seeing is believing. Let me see that all the data is actually right, because at the end of the day, these are all data that patient is providing, right? There was a report that I read about physicians asking how are we sure that these data are actually accurate, that the data was not manipulated? Because just like you said, cost, right? If your social structure your social aspects, there are other problems that you're facing, and this becomes a question: what would be your priority? But technology and outcomes, and where RPM is going to lead, we do not know. Okay, I love the conversation, but the longer we keep this, the lesser people are going to be interested in listening to us, because, but this is so close to our heart. I know we can talk for hours about this. I want to do a little segment that I've been planning to do. I am planning to do in every episode, where we do a few questions that we do like a rapid fire. Okay. So
Let's
I
go.
want to unmute. I'm going to go for 5 questions or so. 24/7 monitoring, necessary or nice to have? Romanus, is it necessary or nice to have? 24/7.
Depends on the acuity. Depends on the acuity.
Good.
Depends on the acuity of the patient. If they're really, really high risk and requires
Let's say high
hospital at
risk.
home, okay, hospital at home, then yes, absolutely critical. Again, to Raphael's point, if you risk stratify them and they're in that bucket and the high risk of readmission because they have a utilization rate that is ridiculous, yes, check mark, check mark, check mark.
Yes.
Yeah.
How about you, Rafael? Need to have or nice to have?
I'm sorry, question?
The question is 24/7 monitoring. Is it need to
I,
have or nice to have?
I agree with him 100%. It's going to depend on the acuity of the patient. Like he said, very high risk patient discharged. We want to monitor them.
Mm-hmm.
For a rapid
Period.
fire, you guys are agreeing too much with each
I don't
other.
know.
For our listeners, it's just a side note joke that we have. Please ignore whenever he says R&R.
It's real.
Easier to justify FFS, fee for service, or value based care? Rafael, you go first.
Value-based care.
Yeah.
All day.
Okay.
Same.
Romanus?
Yeah. 100%.
You guys are both value based care. I kind of expected this. You disagree with what
value-based care equals outcomes, period. Raphael knows this.
Absolutely.
That's it. 2 words.
There's been a transition since, we'll say the Affordable Care Act. And obviously now with the new administration, even more on quality, giving more power to the PCP because they're ultimately the quarterback, really taking care of the patient. So it's value-based care. That's the future of healthcare in the United States.
I completely agree. And we at Equipo Health, that's the core value that we keep. For us, we run our entire circle of care runs around value-based care. And with the CMS changes that's just come in with the new codes for RPM, early adopters are going to win. And people who are working with us know that we are already there. We've already started working, and it's already up and running with us. Anyway, so biggest myth about RPM, Romanus. One big myth about RPM.
I'll go.
Yeah, you go.
Let me go. It's going to replace clinicians. Yeah. That's something that's been said since day one, over 10 years ago. Is this going to replace me? Data will never replace you, sir or madam. We need clinicians, and we need more clinicians. So just use this as a tool to make better decisions.
Awesome.
Yeah.
Awesome. Romanus, what about
you? To that point, really, I'll be honest with you. AI's job, or just RPM in general, is not there to replace clinicians. It's to hopefully, it's to protect their attention. Attention on when this goes off.
Yeah.
Where does this patient fall in their normal set of alarms versus this has exceeded some threshold? So I'm kind of advocating to what Rafael said. I really hope that it really protects their attention, because there's so many distractions out there. It's a lot of cool toys.
I like that.
Yeah.
I agree. Completely agree. Probably the last question. One word to describe the future of RPM. One word.
Say explosive. I think RPM, I think everyone will have a device. Every American citizen will have a device at one point consuming information. That is my prediction.
Awesome. Explosive. What a term to use. Romanus, can you beat that?
behavior. I say that just because
Yes.
it's just, do you want to keep this on all the time? All right, let's just say it's so smart now. There's this, I mean, these are smart. These are absolutely smart. And is the signals it's telling you enough to say, with what Rafael said, I want to be around for my kids. I weigh 234 pounds. My step count is much lower than my threshold today, and it's 11 p.m. What am I going to do? Am I going to let that one slide today? And is that going to impact the next day? So for me, behavior. For the patient, and sure, the clinicians at some point, but behavior change for the patient. If that makes any sense,
I like that.
that's a big deal.
Yes.
Yeah.
Putting the two words together, I mean, you spoke about explosive and how every citizen in America is going to have a device, and you spoke about that has to be behavior and priority for them. I mean, what else could end our podcast where we speak about two different aspects now coming together, right? When people really start using RPM for its true sense.
I'll give you one more example. I'll share this. This is private, but my hemoglobin A1C was 13.5. Okay, guys, that is critical. That is actually, even my PCP was like, Romanus, what the heck? How are you even talking and living right now? This was about a year ago.
Yeah.
That motivated my behind to stop drinking when I was drinking, like juice, like crazy. I was drinking it like nothing, and kind of changed. Then it came down to 7. Yes, it's still high, but is that enough? Is that enough? For me, it was. I mean, that was actually very scary. But probably explains why I couldn't see so well.
I just go back to Americans riding blind, not even knowing their hypertension and diabetes is out of control. There's multiple people like you, Romanus, young, older, walking around, and pardon me when I use
ticking
the term,
time bombs.
A ticking time bomb. At any moment, something catastrophic happens. And I'm going to say this, and I hope I don't offend anybody. It ultimately goes down to your children and others to take care of you. You know, you can't take care of yourself when you're in the hospital. You rely on others. So just remember, your decisions affect others.
Absolutely. All right, guys. This was one hell of a conversation. I would love for you guys to come back and join me in Care Conversations, where we're going to speak about more to do with RPM to start with, and maybe other aspects of healthcare which you guys are really, really passionate about. So to all the listeners of our podcast, all our viewers, team up with Equipo. Let's simplify healthcare together. Thank you, guys.
Thank you.
Thank you, Fancy. Take care.